Ah, but that's a pragmatic argument. That's not saying in principle it would be better, that's just saying consequentially they turn out worse.
Right, okay, so this is the end of a video which Sargon of Akkad did, which was a response to a video which Rocking Philosophy did, which was politely targeted towards Sargon of Akkad. Now, at the end he starts going through the NHS, and I just want to add some information which goes counter to what Sargon of Akkad said. Now, first of all, I just want to mention I'm not an expert on the NHS. I just started looking into the NHS about a year ago, and I've only read a few books up to this present point. So if anyone's got any information which goes counter to what I'm saying, please send it to me.
And this is my argument for universal healthcare. Consequentially, it's worse to have private healthcare. And well, let's not say, I'm actually not in disagreement that the market should be able to provide an alternative to a universal healthcare system. Absolutely. If you can afford to have private healthcare, you can do that. And I think you should be able to do that. And yes, it's probably going to be of higher quality, but that doesn't mean that there isn't an advantage.
Now, I just want to pause it here, have a look at the graph shown, and then I will replay that statement back. So we have this graph with life expectancy at birth on the y-axis and health spending per capita on the x-axis. Now, this life expectancy for the USA could be due to other reasons, such as race and culture. Now, I know through this video you were making the arguments for race being a social construct and how the white race doesn't really exist. But when talking about people, it is impossible to collect all the information because we're all different. So with that in mind, we have to come up with these labels in which we can divide people into groups and paint a blur picture, because it's better to have a blur picture than no picture whatsoever. Now, when we look at these charts for race, we can see that there is differences for life expectancy. Now, this could be due to something genetic, something cultural, a bit of both, but there's something there. We also know that there is a difference in the race makeup of Britain, and we certainly know that there is a difference in culture. The average life expectancy tells us almost nothing about the efficiency of healthcare systems, because all it does is push up the life expectancy of a very small percentage of the population. Most deaths are unpreventable, and the lives which could have been expanded, the majority could only be expanded by changing social and maybe genetic factors. I believe it's better to look at the deaths which could have been changed by the systems and look at what systems have a better ratio of saving the people. Now, if we look at this chart for prostate cancer, we can see the United States has the greatest number of incidents, but has the least number of deaths percentage-wise and also number-wise. Now, if we look at this chart for breast cancer in women per 100 females, we can see, yet again, the United States has the greatest number of incidents but the smallest percentage rate of deaths. Now, maybe these charts have been selective, but if someone else has any other information, please send it to me.
And this is my argument for universal healthcare. Consequentially, it's worse to have private healthcare. And well, let's not say, I'm actually not in disagreement that the market should be able to provide an alternative to a universal healthcare system. Absolutely. If you can afford to have private healthcare, you can do that. And I think you should be able to do that. And yes, it's probably going to be of higher quality, but that doesn't mean that there isn't an advantage to also having a public system. For example, if you find yourself unable to pay for healthcare, it would create a better society if we have that. It's also cheaper overall.
Now, I always get sent this chart or quoted the stats from this chart, and to be honest, I don't know what to do with it, because I don't know exactly how the American government spends that money on healthcare. And when I ask, neither do my opponents. But I will explain in a bit why I believe it's an apples and oranges comparison. But first, I want to talk on about another payment in another currency which this graph does not take into consideration, and that's the payment of your time. Now there's a simple rule in economics that if you make something cheaper, then more people will buy it. Now free is pretty cheap. I know it's not free, but people perceive it to be free. And to be honest, it's personally my favourite price. And you will get a percentage of less desirable clientele that wouldn't come otherwise because you've perceived it as being free. Now this is explained in Basic Economics 5th edition, page 52.
In short, more people make more claims on doctors' time under price control, leaving less time for other people with more serious, or even urgent, medical problems. Thus, under Britain's government-controlled medical systems, a 12-year-old girl was given a breast implant while 10,000 people waited 15 months or more for surgery. A woman with cancer had her operation postponed so many times that the malignancy eventually became inoperable. The priorities which prices automatically cause individuals to consider are among the first casualties of price controls.
Now these extra patients also cause extra drain on the state. So what the government will do, which is running a government-run single-payer health service, they will limit the amount of supply to bottleneck the demand.
All the other English-speaking countries, Australia, Canada, New Zealand, and the United Kingdom, had more than 20% of their patients waiting more than 4 months, with 38% of those in the United Kingdom waiting at least that long.
This is the extra payment, and the currency is time. Now it's impossible to add this into the graph because you may be willing to pay to decrease the waiting time for, say, if you have cancer, but you're not willing to pay to decrease the waiting time if you just need your toenails clipping. But I think it needs to be taken into consideration when looking at this graph. The NHS is not free at the point of use. You're paying for it with your time. Now on to the apples and oranges comparison. Like I said before, a single payer health system will decrease the amount of supply to bottleneck the demand, where that doesn't happen in the other case. So the NHS will only buy so many machines, it will only employ so many doctors, and it will only employ so many nurses. This is going to affect the overall payment. Now if we look at this chart of use of high-tech medical procedures, then we can see the US is way ahead. Now if we look at this chart for access to modern medical technology, yet again we can see the US is way ahead. It's an apple and oranges comparison because one healthcare system is limited and the other is not.
The UK spends a lot less per capita on healthcare than the United States does. I think that's a good thing. And I have been in a position where as an individual my life has bottomed out and I've needed a universal healthcare system, and I haven't been able to pay for private healthcare, and rather than going utterly bankrupt and ridiculously into debt, I had my ailments treated and I was sent on my way. And once I carried on working again, I just continued paying the small amount of money I have to pay each month to the NHS.
All throughout this you've been comparing the NHS with an American style system, and now you're comparing the NHS with a system that I only see existing in a third world country. It's a total myth that if you have no money in the United States, then you don't have access to healthcare. First of all, federal law states that they have to treat you.
Many of the uninsured are uninsured by choice, which implies that they have no problem paying for the care they need, they are getting free care, or they relatively healthy and do not see a need for insurance. For example, about 1/3 of the uninsured qualify for government coverage through S-chip for low-income children and Medicaid for low-income families, but have not enrolled. Roughly 1/3 live in households with incomes above $50,000 and apparently can afford health insurance even though they choose not to purchase it. In fact, within the last 7 to 8 years, virtually all of the increase in the uninsured has been among families with incomes in excess of $50,000, and more than half of those earn $80,000 a year or more. Of those who become uninsured at any point in time, Census Bureau data show that about 3/4 obtain insurance within 1 year, while only 2.5% remain uninsured for more than 3 years.
I think also if we're talking about the poor, we need to talk about the inverse care law.
There is no regions of above average spending which are not also high socioeconomic status regions. Indeed, If one knew no other facts, it would be possible to explain 2/3 of the variation in community health expenditure by a knowledge of what proportion of the population in each region were managers, employers, or professional workers. In 1971, Tudor Hart, a general practitioner working in a poor area of Wales, contrasted the availability of medical care in poor industrial areas of high need and affluent salubrious of lower need in memorable terms. He wrote, "In areas with most sickness and death, general practitioner have more work, larger lists, less hospital support, and inherit more clinically ineffective traditions of consultations than in the healthiest areas, and hospital doctors shoulder heavier caseloads with less staff and equipment, more obsolete buildings, and suffer recurrent crisis in the availability of beds and replacement staff. These trends can be summed up as the inverse care law, that the availability of good medical care tends to vary inversely with the need of the population served."
In my opinion, that's not a problem. That doesn't violate any of my rights. That provides a useful and necessary service in the same way that you would argue for the government maintenance of roads, because again, these are in no way a threat to your private property or your natural rights, because I am actually in agreement with you on those points. But ultimately, I'm happy to discuss this further, so if you want to contact me on Skype, we can have a conversation about it, and we can see if we can hammer out these differences. But you definitely had some misconceptions about my beliefs, and so I thought I'd set these straight. I'll leave a link to his channel in the description if you want to check him out. He does good content. I recommend that you do.